Pakistan, and we have panelists Professor Vivek Saraswat from India and Professor Sudhamshu from Nepal. So, without further discussing the details, we'll first introduce our first speaker, Professor Salimur Rahman. Professor Salimur Rahman is from Bangabandhu Sheikh Mujib Rahman University and from Dhaka, Bangladesh. And he has just retired from there, and he was heading the department of hepatology there. So Professor Salimur Rahman would be discussing about the inexpensive testing and treatment of hepatitis C in Asia, and this is very pertinent to our region, South Asia, because as we know that WHO has given the task of elimination of hepatitis by 2030, and 90% of the patients should get diagnosed and treated for hepatitis C by 2030. Are we able to achieve this target or not? This is an issue. But one main hurdle may be the availability of drugs and the diagnostics, that we know these are the expensive tests. And what is the current situation in South Asian countries, in Bangladesh, with availability of generics and inexpensive testing? So Professor Salimur Rahman, over to you.
Mr. Shunan, please give the slides. Yeah, it's okay.
Thank you, Professor Jagam Abbas. Can you hear me?
Yes.
Thank you, Professor Jagam Abbas, for your kind introduction. And my thanks to the organizer, especially the president of the organization, Professor S.P. Singh, and Secretary General, Professor Mamoon Al-Mahatab, and other member of the scientific committee and the other executive committee members for inviting me to give a webinar lecture on hepatitis C, especially the inexpensive testing and treatment of hepatitis C in Asia. And I must also thank my younger brother, Professor Fazle Akbar. It is a great honor for me to see him as the chairperson. First, I will give some brief points, about hepatitis C. Then I shall go to my main topics. All of you know that the HCV is a silent killer. There is the Bangladesh prevalence is about 1%. The worldwide prevalence is about 2 to 3%, and it is 4 times more prevalent than AIDS worldwide, and it increases the risk of HCC by 25 folds. And all of us know, as the moderator has already said, that there is no vaccine available to prevent hepatitis C. And these two gentlemen, Mr. Daniel W. Bradley and Michael Houghton of Chiron, and they together identified the virus in 1989. We know that the chairman has already said that the COVID virus and the hepatitis C virus both is a RNA virus, and the hepatitis C has 6 genotypes with 100 subtypes with high rate of mutation. I have already said the world prevalence is about 2 to 3%. And in Bangladesh, we made a study near Dhaka, and it was found to be about 8.8%. In this subcontinent, the prevalence rate is almost the same, except in Pakistan, which is a little higher than other neighboring countries. In neighboring countries, this is a very important slide in respect of my inexpensive treatment, and this is the natural history of hepatitis C we know that it takes about 15 to 20 years to develop chronic liver disease, end-stage liver disease, cirrhosis, and hepatocellular carcinoma. And that point, it is very difficult and very expensive to treat hepatitis C. So I must say at the beginning that if you can make an early diagnosis and treat the virus and eradicate the virus, it will help us in different ways in economically. So we can treat the patient at early stage in a lesser price. And also, if you treat the patient at early stage, there is no chance of transmission from that patient to others. And that will also save money, and that will make the treatment inexpensive. Thank you. South Asian and in neighboring regions, the genotype is mostly genotype 3. In Bangladesh, it is also majority is genotype 3. And all of us, we know that it is the most difficult to treat genotype. Most difficult means you have to give more drugs, and there is sometimes relapse, and you need to spend more money to treat this genotype. What is our goal? Our goal is to eradicate the C virus and to achieve SVR. If we can't achieve SVR, then there will be relapse and there will be more money is spent. So the drug should be that it achieves about 95% SVR, so that we can nicely treat the C virus. The HCV treatment includes serological testing, confirmation of the active infection by HCV RNA, treatment assessment, and monitoring. We can reduce the cost of management in above all the phases of the management, in all the phases of the management. We must have pre-therapeutic assessment by doing liver disease severity, by seeing the liver disease severity, by presence of, to see the presence of cirrhosis and the presence of decompensation, because otherwise, if you treat a decompensated disease in a normal way, then patient will recur, and inexpensive treatment is not possible. So we must know the stage of the disease. There is a new test which is known as HCV core antigen, though it is not available in Bangladesh, and it is known as HCV core antigen testing, and it may be compared with HCV RNA measurement. Hepatitis C virus load detection and quantification is routinely accomplished by HCV RNA measurement, and which is a very expensive but essential test both for the diagnosis and treatment of chronic hepatitis C. HCV core antigen testing has been suggested as an attractive alternative to molecular diagnosis. HCV RNA is to be done only in HCV core antigen negative cases to detect the false negative cases, because in some of the cases, the HCV core antigen testing becomes false negative, and in those cases, we must confirm the infection, active infection, by doing the HCV RNA. So in many cases, we can, most of the cases, we can avoid doing HCV RNA by doing the HCV core antigen testing. Who should be treated? All patients, irrespective of the degree of fibrosis, are a potential candidate for the treatment. Treatment may not be initiated in patients with severe comorbid condition whose life expectancy is less than 12 months. In these cases, if you start treatment, that will not give benefit, and inexpensive treatment or wastage of money is possible in those cases, because this will not give benefit to the patient. So in those cases, we should avoid treating patients. What are the FDA-approved drugs: pegylated interferon, ribavirin, sofosbuvir, daclatasvir, ledipasvir, velpasvir, and the direct-acting antivirals fixed-dose combinations are also approved. And I have not mentioned the other drugs because these are not available in this region. And there is a newer approval, voxilapravir, and also glycapravir and pibrentasvir. If you treat glycapravir and pibrentasvir, and it needs only 8 weeks, and if you can reduce the money, that means if we get the generic form of this glycapravir and pibrentasvir, then we can reduce the cost of the treatment in this part of the world also. But what is pangenotypic DAS? Sofosbuvir, velpatasvir, sofosbuvir, daclatasvir is a pangenotypic DAS, and in my country, sofosbuvir, velpatasvir is nowadays mostly used. We can add ribavirin also in genotype 3, especially in cirrhotics, and also to reduce the duration of the treatment to achieve more SVR. So by using these pangenotypic drugs, we can avoid doing the genotyping, which will also reduce the cost of the treatment. Treatment monitoring. We should monitor the patient, monitoring of the treatment efficacy and monitoring of the treatment safety and detection of hepatocellular carcinoma is the monitoring. So in these aspects, we can reduce the cost. In patients treated with an interferon-free regimen, HCV RNA or HCV core antigen level should be measured at the baseline and at 12 and 24 weeks after the end of the therapy to assess SVR12 and SVR24. Initially, in interferon era, we used to do RNA after 4 weeks and also at the end of the treatment. That we can avoid with direct-acting antivirals, and that will also reduce the cost. Monitoring of the treatment should be simple, and ALT can be done at the baseline and at 12 and 24 weeks post-treatment, and in some cases, if there is symptom and detection of hepatocellular carcinoma, we can do only ultrasound or AFP. Both may not be done to reduce the cost. In renal impairment, we can use, and we are using sofosbuvir and velpatasvir in the normal doses. In genotype 3, we are adding ribavirin, and that will reduce the cost if you avoid the more costly drugs for treatment in renal impairment patient. These are the ideal characteristics of an HCV drugs. SVR should be more than 90, low toxicity, well tolerability, short duration, high barrier to resistance, one type fits all, that means pangenotypic, minimal drug-drug interaction, and low pill burden. The generic variety of sofosbuvir and velpatasvir possess the above mentioned characteristics, and we can ideally use those generic sofosbuvir and velpatasvir to reduce the cost of the treatment. Despite the availability of highly effective therapy for hepatitis C virus infection, few patients receive treatment due to barrier at multiple levels. At the patient's level, there is lack of awareness, fear of side effects, poor adherence, and comorbid conditions. At the provider's level, there is limited knowledge, lack of availability, and communication difficulties. At the government and payers level, there is lack of promotion and surveillance and funding. By improving this situation, we can reduce the cost and we can make the diagnosis at the earliest stage so that treatment cost can be reduced and it becomes inexpensive. So cost is the main barrier in management of hepatitis C. It is because there is regular consultation from hepatologists, which is costly, high cost of the investigations, and unavailability of the some investigation in all parts of the country. Patients obliged to come and stay in the capital, which is also very expensive. Late presentation of the undiagnosed cases with cirrhosis or HCC, so early diagnosis should be made. Huge cost of the drug, almost unaffordable for the middle and lower class people. Fewer number of manufacturing companies, so we should increase the number of manufacturing companies. Less availability of generics in many poor countries in Asia, but it is available in Bangladesh, and there is lack of government program, so we should insist the government to have government program. Cost of the DAs. The cost to treat a single patient with DAs in some high-income countries can exceed $1,000. But the introduction of generic version of DAs, the price in other countries such as Bangladesh and around us is about $600 to $700 to treat a single patient. This is a great advantage. The cost and budget impact of treatment with DAs. The price of DAs are falling in a number of countries as a result of price negotiation with the manufacturers and through the introduction and registration of generic medicines. Due to lower price in some countries, expanding access to the treatment using DAs resulting in better rates of cure. Cost effectiveness of the hepatitis C treatment, which is expressed in ICER, that is incremental cost effectiveness ratio. The ICER estimates how much one needs to pay to gain one additional quality, that means QALY. The study results, treatment compared with no treatment, incremental cost effectiveness ratio in HCV infected person without cirrhosis, $349 per QALY cost saving, and with cirrhosis there is saving of $324. And in general, if you don't consider with or without cirrhosis, then there is savings of about $344. So for each HCV infected person, DA's treatment as compared to the non-treatment leads to quality adjusted life years improvement of 3.8 years and lifetime healthcare expenditure reduction by $1,302. WHO recommendation is that offering treatment to all individuals diagnosed with HCV infection, use of pan-genotypic DAs regime for the treatment of persons with chronic HCV infection, which I have already mentioned in my previous slides. How to overcome the barriers? For overcoming the barriers of hepatitis C treatment, WHO has recommended a general consideration emphasizing on using pan-genotypic DAs therapy and a simplified service delivery model for the government to implement, targeting on early detection of hepatitis C, not only to prevent hepatocellular carcinoma or liver failure, but also to check the spread of HCV from infected to uninfected person. So, Mr. Chairman, sir, our take-home message is that with the introduction of DAs, more than 95% of the patients with chronic hepatitis C can be cured. After the introduction of generic products, the cost of the treatment has come down to near acceptable levels in Asia. The use of pan-genotypic regimen obviates the needs for genotyping before treatment initiation. In resource-limited setting, the assessment of liver fibrosis using non-invasive tests reduces the complication, thereby reduces the cost of the treatment. The government and the non-government organization can help the patients providing health insurance and easy term loan facilities to the poorer for management of their disease. Thank you all for your patience hearing. Thank you.
Thank you very much, Professor Salimur Rahman, for this excellent presentation. With the permission of Chair, we may have the question and answer session at the end of the webinar. So, in that,
I think Professor Abbas, it would be better to have at the end, because I'm not exactly sure at which positions it's going on at about the time. So let's make it at the end or at the expert level.
Okay. So we move to the next speaker. Our next speaker is from India, Dr. Pankaj Puri. And Dr. Puri is the Director of Gastroenterology and Hepatology, Fortis Escorts, Liver and Digestive Disease Institute, Fortis Escorts Hospitals, Delhi. So Dr. Puri would be discussing about difficult to treat hepatitis C patients. Over to Professor Puri.
Thank you, Professor Zaigam Abbas. It's a pleasure to speak to this wonderful audience. And my task will be to speak on difficult to treat hepatitis C patients. See, if you look at the countries which are accounting for 80% of the total viremic HCV infections, we find that South Asian countries, including Pakistan, India, Bangladesh, these are very high up in the list of countries which account for this viremic burden. The prevalence of hepatitis C is ranging between 0.5% and a very high prevalence in Pakistan. And a dominant genotype in most countries is genotype 3, though there is some differences. From Sri Lanka and Indonesia, there are different reports. The newer and newer drugs are being approved for treatment of hepatitis C, and we started with interferon, went off to pegylated interferon, and thereafter the DAs came, which started to improve the treatment response, and then came the newer DAs, which are giving almost just short of universal response. If you look at the available DA combinations, which have been recommended by the guidelines, of course there are many more. These are the DAs which are currently available with us in country and most of South Asia. Of course, lecaprevir, pibrentasvir, and voxilaprevir are other drugs which are not available, which are also pangenotypic. So as far as we are concerned, the pangenotypic ones are soft along with either velpatasvir or declatasvir. However, when you look at the guidelines, declatasvir is nowhere on the horizon in their recommendations. The pangenotypic regimen which are recommended are those with velpatasvir or lecaprevir, pibrentasvir. Ledipasvir has been used only for Geno 1, 4, 5, 6, and the other regimen has got limited efficacy. Both ASLD and EASL with mild modifications are recommending simplified regimen, which include these two pangenotypic drugs without too many investigations. The past concept of difficult to treat hepatitis C has evolved over time. We used to worry about genotype 1, we used to worry about high viral loads and unfavorable IL-28B polymorphisms. All these have changed. Currently, unlike Geno 1, Geno 3 is the one which is probably the one with worse outcomes. Decompensated cirrhosis and DA failures are reason to worry. Some of the other difficult to treat are those which respond, but you have to be careful in the treatment and the drugs which they can tolerate. Affordability has always been an issue, but in the present DA era, what is new is that lack of access to new DA therapies is a problem which is specifically there in South Asia. So I'm going to look at some of these difficult to treat hepatitis C, the dominant among them being decompensated cirrhosis, liver transplantation, treatment failures, co-infections, kidney disease, children, especially with focus on genotype 3, and how do we treat in resource-constrained scenarios. Look at this patient who's got decompensated cirrhosis. Her MELD is 20. Questions which we ask is, which DA should we use? Is the SVR same? Are they going to tolerate the drugs well? Will she improve enough to get off the transplant list? And if we have listed her on the transplant, should we treat before transplant or should we treat after transplant? There are many pros and cons of treating before and after liver transplantation. Patients may actually improve and get off the transplant list. We will prevent the post-transplant recurrence. And sometimes if transplant is not available, this is the only thing to be done. We don't have transplants, you treat them. The cons are there may be potential deterioration. The SVR rates may be lower than after transplant. And if the treatment is failed, then the patient may get resistance. One other problem is that they may respond, their MELD may go down, their priority to liver transplant will go down, and they will be having a poor quality of life. If we look at the various trials, while there has been improvement with DA, there are many patients where there is actual worsening of therapy with DAs as well. This was the landmark trial where 103 patients were treated. And of these 103 patients, 1/3 of them were inactivated or placed on hold on the transplant list, and 1 in 5 actually went off the transplant list. The ones who really improved are the ones with lower MELDs. What is the cutoff? So this is one study which showed us that the cutoff is 20 if the improvement is limited to patients with a MELD score of less than 20. Other studies have looked at various factors associated with delisting. These include body mass index, encephalopathy, ascites, ALT levels, and albumin levels. But basically, in a nutshell, if the patient has poor MELD, is sarcopenic, less likely to respond. We need to be treatful. When we treat these patients, we need to be careful. No protease inhibitors. Some of these newer drugs are not to be used. The DAs, other DAs like SOF, velpatasvir, ledipasvir can also cause injury, so we need to watch them carefully. Ribavirin can cause anemia. Usually ribavirin would be used in these patients, but we must keep MELD purgatory in mind. This is something which I will discuss a little later. See, purgatory in Christian mythology was a place between earth and heaven, and the souls of sinner would go there to amend for their sins before going to heaven. So treatment with DA is a little bit like that. Patients would improve. Patients would treat with DA would have improved MELD score. They would not be sick enough to transplant, but they will lose their priority for liver transplant. They would have a poor quality of life, and the complications of portal hypertension and hepatocellular carcinoma would all be there. They would have, let's look at the response rate to DAs with decompensated cirrhosis. These would be lower. The patients, if you look at the study, this was the Ali-1 study, and you look at the role, the efficacy of SOF and DACLA plus ribavirin for 12 weeks, we find much lower response rates with patients who had child C cirrhosis. Similarly, this was Ali-3, which had included patients who were treatment naive and experienced, and we find much lower response rates. These brown bars are the patients with cirrhosis. Whether they were treatment naive or treatment experienced, the response rates were much lower in patients with cirrhosis. Again, SOLAR-1 and SOLAR-2 trials, reasonable reports, but if you look at the response rate, 70 to 87% are much lower than what you would find in patients who do not have cirrhosis. Real-world data has also shown much lower results in cirrhotics, and genotype 3 response rates were as low as 68%. This was Astral-4, where we now are using velpatasvir, and this was a study where they had 3 arms: SOF velpatasvir for 12 weeks, along with ribavirin for 12 weeks, or SOF and velpatasvir for 24 weeks. What strikes out in this study is the response of Geno 3. You find that here this blue bar is the ribavirin bar. We find this 12 weeks patient, when the patient is given ribavirin, the response rate is much higher, and without ribavirin, the response rates are just about 50%. So genotype 3 in particular appears to benefit from ribavirin. The ELITA consensus transplant society also shows that if the MELD is between 20 to 25, only a few handful of patients will improve and can be delisted. Similarly, the International Liver Transplant Society is saying that if the MELD is less than 20, You give antiviral therapy before transplant, and people who have very high MELD scores should not be treated, and they should first undergo liver transplantation. The principles of therapy would be treatment based on NS5A plus SOF plus ribavirin. And if they cannot tolerate ribavirin, we would increase the duration to 24 weeks. We would not give them protease inhibitors. And people who are treatment experienced, again, would have higher prolonged therapy. If you use DACLA, which we usually would not, again, the treatment should be 24 weeks, mainly because the data with DACLA was of lower in cirrhotics. So if transplant is not an option, like in this box here, then you would give DAs. If transplant is an option, then you look at the MELD scores. If the MELDs are more than 20, do transplant. MELD is 16 or below, give DAs. Between 16 and 20, I think a lot of counseling is required before you make this decision. These were the AASLD guidelines on treating people with decompensated cirrhosis. They all added ribavirin. Velpatasvir was there in all genotypes, and ledipasvir only in genotype 1, 4, 5, 6. The EASL guidelines, on the other hand, these have been published only recently. They are ahead of print, and they have come out only a couple of weeks back. These are saying that people who have decompensated cirrhosis, or who are right now compensated but have had a previous episode of decompensation, should only be given velpatasvir. They are not giving ledipasvir as an option in this guideline. There has been debate on development of hepatocellular carcinomas, and this is another paper which has come out recently, that unlike similar to pegylated interferon, there is no higher HCC development with DAs. With this fear was always there. We need to monitor them closely, and if they develop ascites, jaundice, encephalopathy, we stop the therapy. We monitor anemia if they are on ribavirin, and the other monitoring of hepatocellular carcinoma varices may also be there. We must remember that most of them will continue to need a transplant, and only 1 out of 5 will go out of transplant list. Post-transplant hepatitis C, this is a second issue. About 1/3 will develop cirrhosis within 5 years without antiviral therapy, and a small fraction may develop fibrosing cholestatic hepatitis. The right time to treat them is generally about 3 months. When the post-op issues are resolved, the renal functions are normal, they have stable immunosuppression and no ongoing rejection. We must keep drug interactions in mind. Again, the AASLD guidelines are recommending either use of glecaprevir, pibrentasvir, which we don't have, or use of NS5A inhibitor, velpatasvir, ledipasvir, along with SOF for 12 weeks. In case they have decompensated, we add low initial dose ribavirin, and if their treatment experience, the regimen of voxilaprevir is recommended. Previous treatment failures, we've had 2 trials, these are Polaris 1 and Polaris 4 trials, which are, the first one was Geno 1 and the second one was Geno 1 to 3. And they used voxilaprevir in people who had treatment failures, and the response rates were 98% with this regimen, unlike only 90% in SOF and velpatasvir. Our problem is we don't have the form of regimen easily available with us. The AASLD guidelines, I have divided these people into people who have pegylated interferon experience, only sofosbuvir experience, and patients who have NS5A experience. Now, if patient has previously received an NS5A experience, and this is our problem area, the only regimen which is recommended is SOF, velpatasvir, and voxilaprevir. So the EASL again is recommending SOF, velpatasvir, and voxilaprevir. However, there is an even more convoluted regimen which has come out in this EASL guidelines, where they have used SOF, glecaprevir, pibrentasvir, along with ribavirin. And these are, of course, small number of cases which have been tried. If the patient is decompensated, or patient cannot get voxilaprevir, you give velpatasvir and ribavirin. So what do we do in India and Asia? Pegylated interferon failures, we are seeing less and less of these now. Standard treatment for genotype. If the failure only SOF, with failure of SOF, we'll probably use velpatasvir and ribavirin. If there's a failure to previous NS5A, resistance treatment testing if feasible and treat accordingly. If treatment is no urgency, we procure Velpatasvir, Voxilaprevir on compassionate access and treat these patients. We would add ribavirin. If we don't get this drug, we will use soft, Velpatasvir and ribavirin, give it for 24 weeks. And that is the regimen which we would use if there is urgency in treatment or cost is an issue in procuring Voxilaprevir. HIV co-infection was always a worry. However, we find that the SVR is similar to mono-infected people. The most important problem here is that there are a lot of drug interactions and we have to manage these drug interactions. Soft and Velpatasvir can be used in most drugs except efavirenz and nevirapine. One drug which we need to keep a watch on is tenofovir. Tenofovir levels may increase along with soft and Velpatasvir or ledipasvir. We need to monitor renal functions and consider change to TAF, alafenamide, tenofovir alafenamide. These were the regimen which have been recommended not to be used along with ASLD, and I'll skip a little bit of this. Similarly, a new EASL guidelines has come out with a nice chart where you look at the various groups of HIV drugs, and the green are safe, the orange are where you need drug adjustment, and the red ones are where you avoid. So whenever we give these new drugs, we must check drug interactions, and this is a very useful website, which is the Liverpool website. Don't trust your memory. We got to look up all drug interactions which are given when we give a patient treatment for HIV and similarly any other drugs. Here's a patient with hepatitis B infection. Important part is this patient has EAG negative and DNA negative. Of course, he's got active hepatitis C. And what do you do with this patient? If you look at the EASL guidelines, they go ahead and recommend concomitant nucleoacid prophylaxis until week 12 after DA therapy. I mean, everybody, irrespective of DNA status, would undergo therapy as per the EASL guidelines. But that's something which is got to have its own debate, because you're going to stop the drugs, you're going to likely to get drug resistance. And it's more important that you look at the cirrhotic status, you look at the fibrosis status. If the patient has high fibrosis or cirrhosis, then the nucleic acid analogs must be started before or together with DAs, regardless of viral loads, because you worry about reactivation. If patient doesn't have cirrhosis, we can monitor these patients without necessarily giving antiviral therapy across the board. CKD was always a worry, and we used to wonder that we don't have drugs to treat, but this has come out recently. This is soft and Velpatasvir for 12 weeks in hepatitis C infected patients with ESRD undergoing dialysis. And the cure rates were 95% and it was safe. Similarly, data from India, which has come from SGPGI, which showed that it is safe to use. And a meta-analysis of 21 studies has shown that soft-based regimen might be safely used and effectively used in patients with CKD with either normal or reduced dose of soft. The ASLD has also come out and said that there's no drug adjustment required, and FDA in 2019 November has allowed the use of soft-containing regimen in patients with renal disease. So this is one issue which is getting resolved. Children with hepatitis C, many drugs we don't know how to give, what doses we should give. This was a study which was done from Dr. Dhiman's group in a PGI Chandigarh. Children are aged 12 to 18 years. If they were non-cirrhotic, they were given DACLA. If they were cirrhotic, they were given as per the genotype. And the dose was half if the weight was less than 35 kilos. So if the patient did not have cirrhosis, they didn't really do genotype. If the patient has cirrhosis, they did genotype, and they gave half the dose as per the body weight. But our worry is more about children who are 3 to 12 years of age. This is data which has come out this year in Jan 20 in hepatology, and which has shown good efficacy of soft and ribavirin. And similarly, data of ledipasvir, which has again come out this year, which is showing good efficacy. So recommendation for children are we should treat them when they're more than 3 years. If they're beyond 12 years, you treat them as adults. Between 3 to 11 years, we use soft Velpatasvir, and the dose should be depending on their body weight. If they are more than 17 kilos, then half the tablet. which is SOF and valprotasvir, basically half the dose, and ribavirin if required as per body weight. Last issue is treating as per genotype 3. One of the, if we have a lot of genotype 3, and lots of people are saying it doesn't matter, but overall genotype 3, the major issue, first issue is that it is soft daclotosvir use is being done rampantly in India without it being recommended by any of the guidelines. SOF is effective and a lot cheaper. If you look at the initial trial, which compared glecaprevir versus SOF on the basis of which glecaprevir came into being, you find that actually the response rate of DACLA group, which is in the middle, is better. It's not in any way worse. Not better, but at least not worse, numerically better. Similarly, other trials have also shown that the efficacy of daclotosvir is very good. Real world data, this was on 5,400 patients who were given daclotosvir plus SOF with ribavirin or valprotasvir with SOF plus ribavirin, and we find that the response rates were very good. The chance of achieving cure was the same whether the patient received dacla plus SOF or valpa plus SOF. Data again from Thailand, which is showing good response. Indian data again showing good response. So we wonder why we never recommended, why the new guidelines have got rid of this drug without its. EASL 2020 has come out with a small little paragraph which says in low and middle income countries where pangenotypic DA combinations are not available or not affordable, the pangenotypic combination of generic sofosbuvir and generic daclotosvir is safe, highly efficacious, and affordable. I still wonder why it's not part of the regimen. So ribavirin requirement data has shown that in compensated cirrhosis it is important, and this is an issue which I will just cover. That there is resistance associated regimen is resistance testing is recommended before starting treatment in patients with Geno 3 who have cirrhosis or are treatment experienced. The recommendations for ASLD tell us that we must check for resistance testing, and if the patients have resistance, then you either give voxilaprevir or you add ribavirin. If you're not going to do resistance testing, we must add ribavirin to our regimen. So all our Geno 3 cirrhotics should have ribavirin added. The last is resource constrained scenarios. Investigations I will not go through because these have been dealt by my previous speaker. Data to show generics are as good, and the cost effectiveness of generics have also been shown by Dr. Rakesh Agarwal. Many countries, including our own countries, have access to care programs. So the carry home messages are, if the patient has decompensation, if the MELD is less than 20, you give DA before transplant, and treatment of choice would be SOF, valprotasvir with low initial dose ribavirin for 12 weeks, or if they don't have tolerate ribavirin, then 24 weeks. Post-transplant, give treatment within first 3 months, and SOF valprotasvir for 12 weeks would be the first thing. We must check all drug interactions and add ribavirin if they are decompensated. Treatment failures, this is the group which is important, NS5A. We either add ribavirin and give it for 24 weeks, or we get voxilaprevir, which we are getting in our country through compassionate use program. HIV, important to recognize drug interactions, and SOF, ledipasvir or valprotasvir can be used safely in most patients. We have to have care with the use of tenofovir as a part of heart regimen. HBV, if they have cirrhosis, you start nucleoside analogs before you start DAs. CKD, all our fears have been allayed, and we can give sofosbuvir safely. Children who are more than 3 years, we should give treatment which is based as per their body weight. In genotype 3 compensated cirrhosis, we must add ribavirin. And if the patients have resource constraints, we must use pangenotypic cheaper regimen. Rationalized investigation. We must have DACLA as a part of our armamentarium. The efficacy has not shown to be really inferior. Probably may not be so great in cirrhotics, but otherwise it's good. Finally, when we worry about what is difficult to treat, I think the most difficult to treat are the people we don't recognize. We are seeing only just some things on top, but there's a huge thing at the bottom. huge HCV, which we are not seeing, and that's the one which we need to target. So that's a little photo of our team, and this is Dr. Acharya, and we have a great and happy team. Thank you so much.
Thank you very much, Dr. Pankaj Puri, for this excellent presentation. As you have said that we are seeing the tip of the iceberg, and we'll have to find out missing millions that we don't know of. So another thing about care of hepatitis patients is hepatitis C patients. Then after we have treated our patients, then we abandon our patients, and that is the big issue in third world countries. These patients get lost to follow up, and they don't come back to us. To further throw light on this aspect of care that is required after eradication of hepatitis C, we have with us Professor Saeed Hamid. Professor Saeed Hamid is the Director of Clinical Trial Unit at Dhaka University Hospital, and he's Professor and Consultant Gastroenterologist in the same hospital, and he's heading the WGO Hepatology Interest Group also. So over to Professor Saeed Hamid.
Thank you, Zagam. Can everyone see my screen?
Yes, we can see.
You can see. Okay, thank you very much. So, as has been mentioned by Zagam, my task is to talk about what happens to patients after they have been treated for hepatitis C. And as he rightly pointed out, the test and treat approach lends itself to people being lost to follow up and therefore suffer consequences, particularly the ones who have liver cirrhosis. So what I will cover is that two messages out front, that there is still a risk of decompensation in patients with liver cirrhosis with hepatitis C that we treat successfully. There is still a risk of decompensation. And there is much talk about whether there is enhanced occurrence of HCC or not, and opinions have swayed back and forth. So we'll cover some data about what is the scenario and what should we do about that. Now, just to quickly, and I just have very few slides. I haven't been able to prepare very well, but whatever we have, let's talk about this. So this is a French study which followed up patients, a multi-center observational cohort study assessing short-term effects of DAs on mortality, HCC, and decompensation risk in people who had been treated and followed up for at least 24 months, a median follow-up of 24 months. In a nutshell, DA treatment was associated with decreased risk of death versus no DA treatment. They could not figure out whether this was liver-related or non-liver-related death was any different because this was a retrospective study, but all-cause mortality certainly was reduced significantly. Having said that, if you look at the two bottom lines, HCC is about the same, whether patients have been successfully DA treated, and these are large cohorts, and decompensation rates are about the same, despite the fact that these patients have been treated successfully with HCC. So the message, the single most important message is that patients, when you start treatment, if they are cirrhotics by any means, if it is ultrasound, fibroscan, even FIB4, APRI, whatever, if you feel that patients are cirrhotics, they should be a mechanism to link them up to further follow-up. Otherwise, we will continue to see some of the consequences of hepatitis C, like liver cancer and decompensation. Okay, so turning to HCC after treatment, which is the main focus of my talk, we now have very solid data with interferon-based treatment because we've done this for a long time. There is long-term follow-up which is available, and therefore we can clearly see that if there is no SVR versus SVR, or SVR with interferon-based therapies very significantly reduces the cumulative incidence of HCC. However, please note that the incidence of HCC does not become zero. It does not eliminate the risk of HCC despite a successful therapy. So there is a role for following even these patients up long term. What is the risk of de novo HCC? And remember, we are now first of all talking about de novo HCC. There's been no HCC beforehand after DAA-based treatment in patients with cirrhosis. And you could easily separate them out into patients who started out with compensated cirrhosis when you treated them, or they were decompensated. And immediately from this study, you can see that there is almost a at least a five-fold increase in the HCC incidence if patients were decompensated at the time of treatment, or versus patients who were compensated. Certainly these characteristics or these incidence rates were worse in Child-Pugh B patients versus Child-Pugh A patients. So very few Child-Pugh C patients, they probably died off quicker and did not develop HCC and so on. So no untreated control group was present in this study, but annual HCC incidence after SVR with DAA is lower than reported incidence with no treatment, which is around 1 to 4% per year, possibly lower than reported incidence after SVR with interferon therapy, which is around 1%. And clearly, the message of the study was that HCC incidence is much higher when patients are decompensated when you treat them. The other factor is that of age. So if these patients are followed up for a sufficient length of time, you can see that they start to distribute out in the age brackets. So patients who are more than 60 years of age certainly have a significantly higher incidence of HCC development versus patients who are, let's say, less than 45 years of age, or even between 45 to 60 years of age. So this gives us clues as to which patients we should really be concentrating on in terms of avoiding HCC or reducing HCC risk. Certainly, patients who are more than 60 years of age are at much higher risk. This is a more direct comparison of interferons versus DAAs. This is not a head-to-head comparison, of course. These are studies that have been done. Obviously, the interferon studies are done previously, and the DAA studies are being done now. And we can see that with interferon, there's a much longer follow-up. With DAAs, the follow-up is accumulating, but it is certainly not as long as interferons. But when you use the same time scales, risk still looks similar when controlled for disease severity. So FIB4 less than 3.25, which means not the presence of cirrhosis, or FIB4 greater than 3.25, the risk is not significant between DAA treatment and PEG interferon treatment. So this is somewhat reassuring data that there is no increased incidence of de novo HCC following DAA therapy. And then we're all aware of this large VA analysis which came out about a couple of years ago, and which clearly showed things that we can already determine, like SVR, no SVR, the risk is higher in patients who have no SVR versus patients who have SVR. And the bottom line of the story is that DAAs do not cause an increased incidence of HCC. However, even here, there was a difference if the baseline status was that of cirrhosis versus without cirrhosis. So that is the key factor for HCC after SVR. And this can be determined easily by using non-invasive tests like FIB4, which were used in this study, for example. Another VA analysis based on approximately the same cohort, comparing historical data with interferon for HCC risk versus DAAs. And the message, two messages quite clearly, that clearly there's a benefit in those who achieve SVR, doesn't matter whether it's with interferon or DAAs. And the curves for the HCC incidence diagnosis probability free from HCV diagnosis, HCC diagnosis, they look similar, whether you look at interferon or whether you look at DA-induced SVR. So again, clearly a differentiation if there was cirrhosis at the time of treatment or no cirrhosis at the time of treatment. And that just presents in another way that there is risk reduction, 71% risk reduction in the incidence or in the development of HCC with DAs only versus 68% with interferon only. So not much of a difference. This is an interesting study, and I would like you to concentrate on this one. And this is looking at short-term HCC risk after DAs. Now, there are a lot of reports out there that HCC develops very quickly in patients who have been treated with DAs. These are large tumors. These are tumors that are generally difficult to treat because they've spread out, they are into the portal vein, etc., etc. So this study looked at what was the profile of these patients in terms of imaging at baseline. So they looked at relative risk by nodules, and they characterized, of course, into three categories: nodule free, so there was nothing, there was cirrhosis, but there were no nodules which would suggest something or the other. There were nodules that could be clearly characterized as benign, for example, things like hemangiomas and so on, or they could be, or there was a category where the nodules could not be categorized very well. And you can immediately see that in the non-categorized nodules, the relative risk of HCC per 100 patients per year was close to 15. And it was significantly different to something which was benign or patients who were nodule free. And therefore, this suggests that these are a group of people where the short-term risk of HCC is the highest and which get highlighted in all the publications and so on and so forth. These could be labeled as regenerating nodules. This could be labeled as dysplastic nodules or whatever, but they're not labeled initially as possible HCC. And therefore, when these patients are treated, there's a significant risk that they will develop HCC. So please be aware of patients who have nodules in the liver, not other than just cirrhosis, visible nodules on ultrasound, and which cannot be characterized very well on different imaging techniques. These are people that you need to concentrate on. So therefore, what about surveillance? Currently, the guidelines from various societies say do this every 6 months, either with ultrasound plus AFP or ultrasound alone, whatever. But I think based on some of this data, we should be individualizing HCC surveillance, particularly in patients who have these so-called non-characterizable nodules at the start of treatment. So maybe we should be ultrasounding them every 3 months rather than every 6 months. These are not part of the recommendations yet, but they may come about to be. However, this has been expressed as a concern after initial concern that the incidence of HCC following successful DA therapy appears to be higher than that observed after interferon therapies. More recent and larger studies have demonstrated that successful DA therapy is associated with a 71% reduction in HCC risk. So they're saying don't stop treating with DAs because there's no risk of HCC. In fact, an improvement. However, patients with cirrhosis have continued risk of HCC, with HCC being reported even 10 years after SVR. So the next scenario is when you treat patients who already have been cured or where curative therapy has been applied for HCC. And this was the first study, if you will remember in all this, by Brig et al. From Spain, which raised the concern. So this was a study of consecutive people with HCV infection treated with DAs after so-called curative therapy for HCC, whatever it was, frequency ablation or resection, etc. And the recurrence rate was HCC recurrence rate was very high, 7.6%, 16 out of 58 cases. Has this stood the test of time? This study again shows similar results to the Spanish study. High rate of early recurrent HCC, whether it was in the scenario of prior HCC or a scenario of liver transplantation. Higher rate of recurrence once the curative treatment had been applied. Why might this happen? Various theories. Reduced immunosurveillance. HCV stimulates immune responses, as we know, and HCV-specific T cells produce cytokines, including interferon, which have anti-cytopathic effect, anti-HCC effects, and even anti-angiogenic effects. And the other supposition is RDA is pro-neoplastic. In other words, they promote HCC growth and spread. There's not really much evidence for any of these. So not everyone agrees. 3 prospective French NRS cohorts of people with HCV and curative HCC therapy. And if you look at the right-hand graph, survival free of HCC recurrence, whether treated with DAs or not treated with DAs, are similar. I think we can probably rest the case that there is a higher rate of recurrence following successful treatment of HCC initially. These are Italian studies, Italian cohorts saying the same thing. Recurrence rate is relatively high at 27% at 1 year, but not increased after DAA treatment. So I think it's natural history coming through of these patients rather than the DAA therapy that has been applied. Does dose timing of DAA treatment after HCC cure matter? In other words, if you treat early versus if you treat late. And this study seems to suggest that the earlier you treat, the higher the cumulative recurrence rate. The later you treat, which means more than 4 months after the initial HCC therapy and cure, it seems to be a less recurrence rate. But this is just one study. It needs to be validated, this concept in other studies before we adopt this. The final word, HCC recurrence rates after HCV-DAA therapy among patients with HCC complete response. Again, no increased risk of HCC recurrence with DAA therapy after complete response for HCV-related HCC in this North American study this time with about 800 patients. So in conclusion, people who've never had HCC before, de novo HCC does not seem to be caused by DAAs, but may occur more than with interferon because DAA patients, remember, we are treating sicker patients with DAAs, more advanced patients. We were never treating decompensated patients with interferon therapy, but now we're treating DAA patients regularly who have decompensated liver disease. And I've already mentioned the presence of this non-characterizable nodules and so on. So we need to do surveillance to these people. But there is data to suggest that it is not cost effective to survey people who have SVR but who do not have cirrhosis. So you will only survey people who have, despite the fact that they have SVR, they have cirrhosis, you will survey them. On the other hand, people who have had HCC recurrence rate may be higher with DAAs than interferon. This is still a matter of debate, but I think there's good data to suggest that that is not really the real world scenario. Treat HCC, including OLT, before treating HCV. Treat HCV after observation period of 3 to 6 months to confirm no HCC recurrence. So give a gap. If you've treated the HCV successfully, give a little bit of gap and then treat the HCV if it has not been treated before. Discuss with patients, image before treatment, and practice close surveillance. Thank you very much for your attention.
Thank you very much, Professor Saeed. So we have with us panelists also, and with the permission of chair, may I introduce our panelists. We have Professor Vivek Saraswat. Professor Saraswat is head of the Department of Gastroenterology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, India. And we have Professor Sudhamshu, and he's Professor of Hepatology, National Academy of Medical Sciences, Kathmandu, Nepal. So welcome, Professor Vivek and Professor Sudhamshu. So your comments.
Yeah, just a minute. So Professor Jagam Abbas, so I just received a message from Professor Vivek Saraswat. He has another appointment, so he has to leave. So you can proceed with the Professor Sudhanshu.
Good evening. Three wonderful talks. There are many things we learned today. So I would like to invite Dr. Puri. He has discussed about the difficult to treat HCV, and we have two questions from the audience. First question is that for compensated cirrhosis with genotype 3, should we always have to add ribavirin for Sofo-Velpa regimen? This is from Dr. Shankar Baral from Patna. Dr. Puri? Is not there?
Can you hear me now? I'm so sorry. Yeah. I was muted. So if you look at the recommendations of genotype 3 for compensated cirrhosis, the AASLD guidelines are recommending that you check the NS5A RAS. If you have the NS5A resistance Y93H, then the patient should have ribavirin. So you have two choices. Either you check resistance testing in everybody, which is the problem with that is availability and cost. If you're not going to do resistance testing, you might as well give ribavirin. So I would say across the board, give ribavirin.
Yeah, because in our subcontinent, we don't have that testing facility. So I think it's better to add ribavirin. Okay. Sure. There's another question. If patient has decompensated CLD and took Sofo-Velpa already here in Pakistan or India, will we proceed with Voxila combination?
See, they are decompensated cirrhosis. They will not tolerate Voxilaprevir. So your choice is to give the same regimen along with the ribavirin. You start low dose initial ribavirin and give the treatment duration for 24 weeks. Or your alternative is transplant him and treat after transplant.
There are no more questions from the audience, but now I'd like to ask Dr. Puri also. This regarding HCV treatment in children, we don't have much cases here in Nepal, but maybe there are some cases in India or Pakistan. Are you still treating those pediatric population below the age of 12 years?
Yes. We are, see, the question is that the data from PGI Chandigarh, they've treated about 57 patients. For the dose recommend, they have used either daclofenavir or velpatasvir in half.
We cannot hear you.
I think he has been disconnected. He will join again later. Dr. Zaigam, Dr. Puri's internet is disturbing. He will join later.
Okay. So may we involve Professor Salimur Rahman? Professor Salimur Rahman, do you have any national hepatitis control program in Bangladesh? And how is this working there?
Government is making program to eradicate hepatitis by 2030. And they have not very elaborate, but they have given free of cost medicine in some of the hospitals, especially the big hospital at Dhaka. And they have also reduced the, they have freed the drugs for tax. They have omitted the tax for import of this drugs, raw materials, so that this can be available to the common people. And government is also in their government television and other medias. They are also giving propaganda and they are also making seminars and symposiums in hepatitis C for the detection of unknown cases so that it can be treated. And their target is to eliminate hepatitis by 2030.
Professor Pankaj, in India, welcome back. In India, we are seeing many cases of COVID-19 there. So what do you feel like how COVID-19 epidemic is affecting hepatitis control program in India?
Oh, hepatitis C is affecting the entire healthcare, and hepatitis control is just one small fraction. And the problem is it's not going away. No vaccine is not going away for a long time. So it is affecting control. People are not willing to come forward. People are deferring all, unless it's a emergency, they're deferring all such things. So the program is being definitely affected.
Professor Saeed Hamid, in Pakistan, what do you feel like the effect of COVID-19 epidemic on hepatitis C control programs?
Well, of course, it has made a lot of difference in terms of the money that is available for the hepatitis C control programs. If you know, as you know, that we were about to launch the national hepatitis program, which has been pushed back because of the COVID situation. Not just the money, but also the difficulty in launching a program. Hopefully, we'll try and do this by the end of the year. But at least, certainly, it has been pushed back by about 5 or 6 months. Secondly, I think there's a lot of still a lot of anxiety and fear and perhaps even stigma around the diagnosis of COVID. So every time you approach a community, they think you've come around to do the COVID testing and so on. So I think that is another thing that we have to deal with to try and get the public opinion on our side when we launch the hepatitis program. Thank you.
So as Saeed, while you are there, you mentioned that there is no increase in hepatocellular carcinoma after successful eradication of DAA. Is there any effect of genotype? Like one genotype is more prone to develop hepatocellular carcinoma as compared to other genotype after eradication with the DAA. Is there any study about that, or there is across the board there is no increase in?
So this is across the board. All the studies that I've shown you have included multiple genotypes, including a fair number of patients with genotype 3. I don't think it is genotype specific, although we keep talking about the fact that genotype 3 may be more carcinogenic as compared to other genotypes. I don't think that that is our clinical experience either. We have 70%, as you know, of our patients with liver cancer are HCV related. But that's because HCV we have a much higher burden of HCV compared to hepatitis B. So the data is not clear whether this is genotype specific.
So you mentioned that after successful treatment of hepatocellular carcinoma, we may delay the treatment of hepatitis C eradication. So.
Right, that's just one study. This is not a guideline so far. So that's just one study to suggest that delaying treatment may be an option. So there's no clear recommendation that we can make so far.
Professor, so one question. Okay, so just I'd like to make one question. So this is so we all are aware about the elimination of the hepatitis by 2030. So and the concept came 2015. Within these 5 years, so how many patients with hepatitis C has brought to physicians or in touch of consultations or other thing, which is a major thing because about the huge proportions of patients are out of reach of the physicians or the medical services. So is there any data? It is common for Nepal, India, and Bangladesh, Pakistan. So for every places. I'm not sure. Is there any? So we all are doctors. So is there any epidemiological data that how the countries are proceeding to bring the undiagnosed hepatitis C patients to the medical community so that they can get the treatment, because we discussed a lot about the therapy, complications of therapy, indications and other things. But how the majority of these patients will be brought to the medical services?
And I think while we discuss any eradication program, we have a model, Egyptian model with us.
Yes.
And that was a very successful model, and they integrated the hepatitis C programs with the basic health center, and they did a lot of advocacy for that. They used media, they used social media for that purpose also, and there was a lot of motivation and will also from the political side also. So I think that aspect is lacking in SAASL countries. Like we do not see much political will